Imagine this. A patient's in crisis. Maybe a stroke, maybe complex heart surgery is underway. The team needs to spot a tiny, dangerous clot hidden deep inside, or fix a small valve tear that's about to cause chaos. Regular scans from the outside, they just can't see through all the bone and air clearly enough. But the decisions are literally life or death.
Exactly, and that's where we need to move beyond just guessing. Your standard surface scan, the transthoracic echo, or TTE, well, it often falls short when the structures are deep or when you need real-time guidance. We need to see what's happening.
Which brings us to transesophageal echocardiography, TEE. This is like the ultimate cardiac detective tool, right?
Right.
It basically gets a camera right behind the heart.
It does. It uses the esophagus as a sort of acoustic window, and this lets us uncover those dangerous, often hidden issues. Think tiny clots, aortic problems, really specific valve details, things that TTE might miss completely.
So today, we're doing a deep dive into what it takes to master this critical procedure. We're digging into comprehensive guidelines based on principles from the Indian Academy of Echocardiography that lay out exactly how T should be done safely and effectively.
Right. Consider this your shortcut to understanding the blend of technical skill and deep knowledge needed for T.
Okay, before we jump right in, we really want to give a special thank you to London Heartbeat Z Academy in the UK for their educational support on this. We absolutely encourage you to check out I think it's over 150 popular courses they offer now.
Definitely worth exploring.
And please do subscribe to their social media, Facebook, Instagram, YouTube. They put out free, regular updates, and you won't want to miss future discussions.
And they also have a higher level YouTube membership, right? For early access to videos, even personal chats and guidance sessions.
Yeah, definitely check that out if you want to go deeper. All right, let's get into the fundamentals. We use TTE all the time. It's standard. So why the extra step, the invasiveness of putting a probe down the esophagus for TE? What's the unique advantage?
Well, it really comes down to proximity and clarity. The esophagus lies directly behind the heart, so there's less tissue like lungs or ribs scattering the ultrasound waves.
Ah, so it's a clearer path for the sound waves.
Exactly. And that clearer path means we can use higher frequency ultrasound. Higher frequency gives you much better image resolution, especially for those structures at the back of the heart, like the atria, the pulmonary veins, the mitral valve, and critically, the left atrial appendage, or LAA. That's a common spot for clots.
So T is like having a VIP pass to the back of the heart. Makes sense.
Precisely. And it becomes absolutely essential when those standard TTE views just aren't good enough. You see that a lot in the ICU, maybe because of ventilators or surgical dressings getting in the way.
Okay.
And in the cath lab or the operating room, T is really the go-to for guiding complex procedures. Think valve repairs like MitraClip, or valve replacements like TVR. You need that immediate real-time visual feedback.
Right, but because it's, semi-invasive, being good at it isn't just reading the pictures. It's about doing it safely. What skills are absolutely required?
Yeah, that's crucial. The guidelines break it down into two main areas: cognitive skills and technical skills.
Okay, cognitive first.
Cognitively, you need a really deep understanding of TTE as a baseline. Then all the reasons for doing T, and importantly, the reasons not to the indications and contraindications. Plus, conscious sedation, knowing all the T views inside out and their anatomy, understanding disease processes, hemodynamics,
Wow, okay.
and knowing the difference between a good quality scan and one that's, well, inadequate.
And the hands-on part, the technical skills, that sounds like where the real challenge might be.
It requires definite skill. You
Yeah.
need to be competent with TTE first, of course.
Right.
Then real dexterity with the T probe controls. It's usually one hand steering the probe shaft, the other working the control wheels.
Mm-hmm.
Plus, knowing how to use local anesthesia effectively, performing the intubation safely, recognizing any image issues or artifacts, and super important, knowing the protocols for probe sterilization.
Which brings us to training. How much practice do you actually need to be considered competent, say, to perform T on your own?
The guidelines are quite specific. For what's called level 2 training, which means you can perform T independently, the recommendation is a minimum of 25 successful esophageal intubations under supervision.
Okay, 25 intubations.
And 50 supervised, complete, multiplanar diagnostic T studies. That's the minimum for level 2. For level 3, advanced training, the bar is higher, 150 Ts in total.
All right, let's pause there for our first question. Based on what we just heard, question 1, what is the required minimum number of supervised, complete multiplanar diagnostic studies recommended for independent performance, level 2 training, in T, according to the COCATS guidelines mentioned? Is it A15, B25, C50, or D150?
Thinking about level 2?
The answer is C, 50. Remember, level 2 requires those 50 supervised complete studies, along with the 25 intubations. 150 is for level 3.
Correct.
Let's make this real with a quick case. How does this apply clinically?
Okay, case example 1, cryptogenic stroke. Imagine a patient has a stroke, but the cause isn't clear from the initial workup, including a standard TTE. It's a cryptogenic stroke of unknown origin.
Right.
This is a prime time for TE because it gives such a clear view of the atrial septum and the aorta. It's the best tool to look for, say, a hole between the atria, a patent foramen oval, or PFO. We use a saline bubble contrast study for that.
Ah, to see if bubbles cross from right to left.
Exactly. Or TE can spot mobile plaques, atheromas in the aortic arch. Both PFOs and aortic atheromas are common causes of stroke that TTE can easily miss. TE is essential here.
Short silence. Okay, moving from the skills to the actual tool. The T-probe, it looks kind of like an endoscope, but it's obviously specialized. What are the key parts?
It is basically a modified flexible gastroscope. You've got the distal tip, which holds the ultrasound transducer, the lens, and the crystals. For standard 2D, that's about 128 crystals.
And for 3D?
For 3D, it's way more, up to 2,500 crystals packed in there. That's how you get those complex 3D images. Then there's the flexible shaft marked with depths. And the handle, that's got the control wheels, a big one for bending the tip up and down, anteflexion and retroflexion, a smaller one for side-to-side bending, plus electronic buttons to rotate the imaging plane, usually 0 to 180 degrees.
Sounds complex to handle. You mentioned safety earlier. What's the absolute #1 safety point related to using the probe itself inside the patient?
Thermal injury. You have to be really conscious of thermal bioeffects. The probe tip can generate heat.
Wow.
The machine actually monitors the tip temperature. If it gets too high, the operator absolutely must hit the freeze button right away. Let it cool down. Otherwise, you risk burning the esophageal wall.
Okay, crucial. Anything else mechanically?
Yes. The locking mechanism on the control wheel. When you're inserting the probe, taking it out, or manipulating it inside the esophagus, that lock must be in the neutral, unlocked position.
Why is that so critical?
If the tip is flexed and then you lock it in that position while trying to move the probe shaft, you could cause serious internal injury. So keep it neutral unless you're deliberately holding a specific view steady.
Got it. Okay, quick check for everyone listening. Question 2. Which component of the TE probe should always be kept in the neutral position when inserting, removing, or manipulating the probe in vivo? A, the electronic rotation buttons. B, the tip cover cap. C, the large anteflexion retroflexion wheel. Or D, the locking mechanism at the inner end of the control wheel.
We just covered this.
The answer is D, the locking mechanism. Keeping it neutral prevents injury from a locked, flexed tip during movement.
Absolutely vital.
Now, safety also means cleaning. This probe goes into the esophagus, so preventing infection is huge. What's the process?
It's rigorous, a multi-step process, usually around 10 steps. Because you're right, the risk of transmitting things like bacteria, hepatitis, even SARS-CoV-2 is real, though thankfully very low, with proper cleaning, like 1 in 1.8 million procedures for upper GI endoscopy.
Okay, what are the key steps?
First, immediately after use, you wipe it down and rinse it. Prevents fluids from drying on it. Then it goes into an enzyme solution, something like cytosine extra, for about 5 minutes. This breaks down proteins and bioburden.
Then the main disinfection.
Right, high-level disinfection. This typically involves soaking in a chemical disinfectant. Common ones mentioned are glutaraldehyde 2% or orthotaldehyde 0.55%, often called OPA.
But there was something specific about glutaraldehyde in the UK.
Yes, good point. Glutaraldehyde 2%, while effective, is actually banned for this specific use in the UK due to health and safety concerns for staff handling it.
Okay, so OPA is the alternative there.
Correct. OPA as 0.55% is the standard high-level disinfectant used in the UK instead. After disinfection, it needs thorough rinsing, usually 3 times for a minute each time, then drying and storage.
How should it be stored?
It should be hung vertically in a clean, dry cabinet, often with HEPA-filtered air to prevent recontamination and allow moisture to drain.
Okay, time for question 3. Why is glutaraldehyde 2% solution, a common high-level disinfectant for T probes, not recommended for use in the United Kingdom? A, it damages the probe housing. B, it causes methemoglobinemia. C, it is banned for this use in the UK. Or D, it requires too long an immersion time.
Thinking back to what we just said.
The answer is C. It's banned for this use in the UK due to safety concerns. OPA-based steam 5% is used instead. Short silence. Right, let's move on to the patient. How do we decide who actually needs a T? What are the main indications?
Well, there are several key scenarios. Infective endocarditis is a big one. T is much better than TTE at seeing small vegetations or abscesses on the heart valves. Another major use is checking for clots in the left atrial appendage, the LAA, especially before procedures like cardioversion for atrial fibrillation or ablations. You absolutely want to rule out a clot first.
Makes sense. What else?
Evaluating valve problems in detail, like figuring out exactly why a valve is leaking or checking how well a prosthetic valve is working. Also, certain congenital heart conditions, like assessing an atrial septal defect, an ASD for potential device closure. And sometimes in emergencies, like suspected aortic dissection, if a CT scan isn't available or contraindicated.
So there are clear reasons to do it. But when is it considered, well, inappropriate?
Yeah, the guidelines talk about appropriate use criteria. T is generally considered inappropriate if you already have a perfectly good diagnostic TTE study that answers the clinical question.
Don't repeat tests unnecessarily.
Exactly. Or for routine surveillance, say, checking on that LAA clot again if the patient is stable on medication and you don't plan to change anything based on the result. Or just screening AFib patients who are anticoagulated but aren't having a procedure like cardioversion.
Got it. And what about absolute deal breakers? When should you absolutely not perform a T?
These are the definite contraindications. Things like recent surgery on the throat or esophagus, any kind of blockage like a tumor or stricture, if you suspect an esophageal tear or perforation, or active upper GI bleeding, especially known esophageal varices.
High risk of making things worse there.
Absolutely. Then there are relative contraindications, things to be very cautious about. Loose teeth are a concern, an uncooperative patient, or a history of radiation to the chest or esophagus, or conditions like Barrett's esophagus. You have to weigh the risks and benefits carefully.
Okay, let's test our listeners again. Question 4. Which of the following is an inappropriate use of T as a first or supplemental test? A. Diagnosis of infective endocarditis when pretest probability is high. B. Evaluation for valve repair surgery. C. Surveillance of an LAA clot on optimal treatment when no change in therapy is anticipated. Or D. Guiding transcatheter device therapy.
Which one doesn't fit the appropriate list?
The answer here is C. Surveillance when no change in therapy is planned is generally considered inappropriate. The others are all strong indications for T.
Correct.
Now, patient prep. Besides the usual fasting for 4-6 hours and getting consent, there is really specific detail about IV lines if you're planning a bubble study. Why the preference for the left arm?
Yes, that's a fascinating point. It's about a rare anatomical variation called a persistent left superior vena cava, or PLSVC.
Okay.
Normally, blood from the left arm drains via the brachiocephalic vein into the right-sided superior vena cava and then the right atrium. But in about 0.5% of people, or maybe up to 4% in those with congenital heart disease, the left SVC persists and drains directly, often into the coronary sinus, which connects to the right atrium, but sometimes elsewhere.
So if you inject bubbles into the right arm, they go straight to the right atrium, but from the left arm.
If there's a PLSVC draining somewhere unusual, the bubbles might not reach the right atrium efficiently, or they might appear delayed, potentially confusing the interpretation of a PFO study. Putting the IV in the left arm covers you for this rare possibility, ensuring the bubbles travel the standard route if a PLSVC is present.
Wow, that's a really subtle but important detail. Okay. Question 5. In case of an anticipated saline bubble contrast study for PFO, why is it preferred to place the IV line in the patient's left arm? A. To avoid interference with ECG leads. B. To reduce pharyngeal anesthesia toxicity risk. C. To account for the rare anatomical possibility of persistent left superior vena cava. Or D. To ensure the patient stays in the left lateral position.
Based on that anatomy.
The answer is C. It accounts for that rare possibility of a persistent left SVC potentially affecting the bubble study.
Exactly.
Let's talk anesthesia quickly. Usually topical spray for the throat, right?
Yeah.
Lidocaine.
Yes, lidocaine or sometimes benzocaine spray to numb the pharynx and reduce gagging. It usually lasts about 30 minutes to an hour. Plus, often some intravenous conscious sedation, typically midazolam, maybe with fentanyl, to help the patient relax.
But you mentioned a specific risk with benzocaine earlier.
Right, methemoglobinemia. It's a rare but serious side effect associated more with benzocaine than lidocaine, especially in certain patients.
And how do you rebut it?
The patient suddenly looks blue, cyanotic, and their pulse oximeter reading drops significantly. But if you check their arterial blood gas, the actual oxygen level in the blood, the PaO2, is normal. That disconnect is the clue.
And the treatment.
Intravenous methylene blue. It works quickly to reverse it. That's why continuous monitoring, pulse oximetry, ECG, blood pressure is absolutely essential throughout the procedure.
And afterwards, what instructions do patients get?
Usually, no driving themselves home if they had IV sedation. They can have fluids after about 30 minutes. Once the throat numbness wears off, then soft food after an hour or so. We warn them about potential sore throat. Major complications like esophageal perforation are very rare, but possible. Short silence.
Okay, the actual insertion. This sounds like maybe the trickiest part technically, getting past the back of the throat.
It does require finesse. There's a sharp, roughly 90-degree turn needed to get from the oropharynx down into the esophagus proper. The absolute key is gentleness. Never, ever force the probe.
So how do you navigate that turn, especially in someone who's awake?
There are basically two common blind techniques. The first involves putting the bite guard in, then asking the patient to swallow. Swallowing naturally opens up the upper esophageal sphincter, the cricopharyngeus muscle, and if you apply gentle forward pressure just as they swallow, the probe tip usually slides right in.
Okay, using the patient's own reflex.
Exactly. The second technique, some operators prefer this, involves using 2 fingers of their own left hand, gloved of course, to gently guide the lubricated probe tip back towards the midline of the pharynx, right to the entrance of the esophagus, before asking the patient to swallow. It feels a bit more controlled for some.
And what about patients in the ICU on a ventilator? They can't swallow on command.
That's different. For intubated, ventilated patients, insertion is often done under direct vision using a laryngoscope, similar to inserting an endotracheal tube. You might need to increase their sedation or even use a short-acting muscle relaxant to facilitate passage. The neck might be gently extended too.
Right, makes sense. Once the probe is in, manipulating it to get all the views seems like another layer of complexity. You mentioned 4 main movements.
Yes, mastering these 4 movements is fundamental to performing a comprehensive T exam. First is advancing and withdrawing the probe along the esophagus. This moves your imaging plane up and down through the heart, from base to apex.
Okay, simple enough.
Second is torquing the probe shaft clockwise or anti-clockwise. This rotates the entire probe in the imaging plane sideways. Clockwise rotation generally moves the view towards the patient's right side structures, like the tricuspid valve or right atrium. Anti-clockwise towards the left.
Got it.
Third is using the electronic rotation buttons on the handle. This electronically sweeps the ultrasound beam itself, changing the angle of the 2D image slice from 0 degrees, typically up to 180 degrees, without moving the probe shaft itself much. This gives you all those different cross-sectional views from the same probe position.
And the fourth involves physically bending the tip.
Correct. That's using the control wheels. The large wheel controls anteflexion and retroflexion. Anteflexion bends the tip forward towards the anterior chest wall, which tilts the ultrasound beam more cranially or upwards. Retroflexion bends the tip backward towards the spine, tilting the beam caudally downwards.
Which of those tip movements is key for getting, say, views deep in the stomach or aligning Doppler properly?
That would be anteflexion. Bending the tip forward or anteriorly is crucial for getting the probe tip positioned correctly in the stomach to obtain the transgastric views, especially for aligning the Doppler beam parallel to blood flow through the aortic or mitral valves to measure gradients accurately. Retroflexion is more for looking towards the LV apex or sometimes moving structures like the IVC out of the way.
All right, another check-in question. Question 6. To obtain transgastric views and allow parallel alignment of the Doppler beam for outflow tract gradients, which probe manipulation is generally required. A. Clockwise torque. B. Retroflexion. C. Side-by-side flexion. Or D. Anteflexion.
Remember bending the tip forward.
The answer is D. Anteflexion. That forward bend tilts the beam up from the stomach, essential for those transgastric outflow views.
Precisely.
And you mentioned different windows based on probe depth.
Yes, there are 4 standard imaging levels or windows. The upper esophageal UE window is shallowest, around 20-22 centimeters from the teeth, good for the aortic arch and great vessels. Then the mid-esophageal ME window, about 28-30 centimeters deep. This is really the workhorse window, where you get most of your standard views of the atria, ventricles, and valves.
Okay.
Deeper still is the lower esophageal LE window, around 38-40 centimeters, near the junction with the stomach. And finally, the deep transgastric TG window, which requires advancing the probe into the stomach, maybe 42-45 centimeters deep, for those short axis and apical views looking back up at the heart.
So a systematic exam covers all these depths and uses all those manipulations.
Absolutely. The key principles are to tailor the exam to the clinical question, but always aim for comprehensive imaging. Minimize unnecessary probe movement, try to visualize the suspected problem early on just in case the exam needs to be stopped, and maybe save uncomfortable maneuvers like Valsalva or very high esophageal views for the end. Short silence.
Okay, let's talk workflow. You've got the probe in, you understand the movements and windows. How do you systematically examine the heart, especially for complex things like structural heart procedures? Let's take mitral valve repair, TEER, using MitraClip as an example.
Right, T is absolutely central to TEER. First, even before the procedure, T provides that high-resolution assessment of the mitral valve anatomy. Is it suitable? We look at the leaflets using the Carpentier classification, A1, A3 for anterior, P1, P3 for posterior, identify the exact location and mechanism of the leak.
Are there specific criteria for TEER suitability?
Yes, ideally it's for non-rheumatic valves, often with the leak originating from the middle scallops, ATP2. There are measurements too, like the coaptation depth needs to be less than 11 millimeter typically, and the mitral valve area, or MVA, should be reasonably large, usually greater than 4 square centimeters, so you don't create stenosis.
And reasons not to proceed.
Definite contraindications seen on T would be things like severe mitral stenosis already present, say, an MVA less than 3 centimeters 6, or, crucially, a clot in the left atrial appendage. You wouldn't want to risk dislodging that.
Makes sense. So during the actual MitraClip procedure, what's T's role?
It's the guidance system. Step 1 is guiding the transeptal puncture crossing from the right atrium to the left atrium with a needle. T ensures this happens safely in the right spot.
Which is where exactly?
Usually in the mid-posterior part of the fossa ovalis, and critically at the right height, typically 4 to 4.5 centimeters above the plane of the mitral valve annulus. This height is important to allow the clip delivery system enough room to maneuver down towards the mitral valve. We use biplane imaging, often 45 and 90-degree views, to confirm this location.
Okay, puncture done. Then guiding the clip.
Yes. We use T, especially 3D imaging, to get the end-face or surgeon's view of the mitral valve from the left atrium. This allows precise alignment of the clip-ons so they are perpendicular to the line where the leaflets meet. Then we guide the grasping of the leaflets, often using an LV-FOTI view, and finally assess the result.
Which involves checking.
Checking how much mitral regurgitation is left, ensuring we haven't created too much mitral stenosis. The gradient across the valve should ideally be less than 4 or 5 millimeter HG, and confirming there's no residual hole where we did the septal puncture.
Perfect segue for our middle case example.
Right. Case example 2, mitral valve intervention. We have a high-risk patient, severe secondary MR, deemed suitable for TEER. T is used right from the start. It confirms the anatomy is good, MVA 4 centimeters. Then intraprocedurally, we use those biplane views, say 45 and 90 degrees, to guide the needle precisely 4.5 centimeter above the annulus in the mid-fossa. Then we switch to 3D on face view to line up the clip perfectly across the A2P2 scallops. After the clip is deployed, TE confirms good leaflet grasp, shows only mild residual MR, and measures the transmitral gradient. It's only 3 millimilli HT successful procedure guided entirely by T.
Fantastic. Let's get another question in. Question 7. During TEER procedures, the T-guided transeptal puncture height should ideally be at least how far above the mitral annulus? A, 1 centimeters, B, 2 centimeters, C, 4 centimeters, or D, 6 centimeters?
Thinking about that crucial height for maneuvering.
The answer is C, 4 centimeters. Remember, 4 to 4.5 centimeters is the target height to allow adequate space for the device.
Correct.
T is also key for ASD closure, right? Assessing suitability.
Absolutely. T is superior to TTE for really defining the anatomy of an atrial septal defect and, importantly, measuring the rims of tissue around the hole. You need adequate rims for the closure device to anchor securely.
How many rims are there?
We systematically assess 6 margins or rims. The SVC rim, superior. IVC rim, inferior. Aortic rim, anterior. Mitral valve rim, posterior, inferior. The posterior rim, and the superior posterior rim. Most need to be at least 5 millimeters long for standard device closure, although the aortic rim is often deficient, and we pay special attention to it.
And briefly, the LAA again. Its shape is complex. How do you ensure you've seen it all?
Yeah, the LAA morphology varies hugely. Chicken wing, windsock, cauliflower, cactus are descriptions used. Because it's often multi-lobed and complex, you need a thorough sweep, usually in the ME views, rotating the probe angle from maybe 30 degrees all the way to 135 degrees or more to be sure you've interrogated every nook and cranny for thrombus.
And sometimes contrast helps distinguish clot from normal muscle.
Yes, especially if there's slow blood flow causing spontaneous echo contrast or if the pectinate muscles look prominent. A quick injection of echo contrast can opacify the appendage and clearly delineate any filling defect that represents a thrombus. Short silence.
Let's shift gears slightly to T in really specific, often critical care settings. What about point-of-care T or POCUS T?
Yeah, this is a growing area. We know standard TTE images can be really poor in ICU patients, maybe up to 50% of the time due to ventilation, dressings, patient position. POCUS T uses a simplified protocol, often just 5 or 6 core views.
Which views are those?
Typically the ME 4-chamber, ME short axis at the aortic valve level, ME 2-chamber, ME long axis, and the ME bicavalval view to assess fluid status. The idea is rapid assessment by clinicians at the bedside, checking heart function, volume status, looking for major problems like tamponade.
Makes sense for quick answers in the ICU. What about patients on mechanical support, like balloon pumps or VADs?
T is crucial there too. For an intra-aortic balloon pump, IABP, T can check for contraindications first, like aortic dissection or significant aortic regurgitation. Then it helps guide placement. You want the tip positioned correctly in the descending aorta, usually 2 to 5 centimeters below the origin of the left subclavian artery.
And for ventricular assist devices, VADs.
Even more critical, T is used before, during, and after VAD implantation. Pre-op, it checks for contraindications like significant aortic regurgitation or intracardiac thrombus. Intra-op, it guides the placement of the inflow cannula, making sure it's positioned correctly in the LV apex or left atrium, not obstructed, not pointing at the septum. Post-op, it assesses VAD function, checks for complications like air embolism, cannula kinking, looks at right and left ventricular function and position of the septum.
Wow, indispensable. Okay, now the ultimate critical setting, CPR. You mentioned T has a unique advantage here.
It really does. During cardiac arrest, trying to get TTE images while someone is doing chest compressions is practically impossible. You have to stop compressions, lose perfusion time.
Right.
T, however, can be performed during continuous chest compressions. The probe is in the esophagus, out of the way. This allows for real-time dynamic assessment of cardiac activity. Is it true standstill, asystole? Or is there organized electrical activity but no pulse PEA?
And can it find the cause of the arrest?
Yes, and this is huge. In maybe up to 20% of PEA arrests, T can identify a reversible cause right there and then. Things like cardiac tamponade, massive pulmonary embolism causing acute right heart failure, severe hypovolemia, even aortic dissection. Finding that cause allows targeted treatment immediately, potentially saving a life.
Incredible. That leads nicely to micro-T. Is that just a smaller probe?
Essentially, yes. It was initially designed for children, but is used in some adults too. The probe tip is significantly smaller, maybe 7.5 millimeter versus 10-14 millimeter for a standard adult probe.
Advantages.
Easier intubation, potentially less discomfort for the patient, maybe lower risk of complications. This could be a real benefit for performing T under local anesthesia rather than general anesthesia or deep sedation.
But there must be a trade-off.
There is. The main limitation is image resolution. Fewer crystals in that smaller tip mean lower image quality compared to standard probes. And crucially, current micro-T probes generally don't support 3D imaging.
Okay, let's clarify that with question 8. What is the main limitation of the microtransesophageal echocardiography probe compared to the standard adult probe? A, it requires general anesthesia. B, it cannot perform color Doppler. C, it does not support 3D imaging. Or D, it has a higher risk of mucosal injury.
Thinking about that smaller size.
The answer is C. The micro-T probe's main drawback is its inability to perform 3D imaging, along with lower overall resolution.
That's right.
Let's tie this section together with our final case.
Okay, case example 3, cardiac arrest in the ICU. You have a patient in the ICU, already on a ventilator, who suddenly has a cardiac arrest PEA rhythm on the monitor. Chest compressions are started immediately. Trying TTE is futile because of the ventilator, maybe surgical dressings.
Right.
A trained clinician quickly performs a post-CST using that focused CPR protocol. Within seconds, the T image clearly shows a large pericardial effusion, fluid around the heart, causing tamponade. The heart is being squeezed.
So the diagnosis is instant during compressions?
Exactly. Based on that T finding, the team can immediately perform an emergency pericardiocentesis, draining the fluid, guided by the T image if needed, all while compressions continue. They found and treated the reversible cause, potentially leading to return of circulation. That's the power of T in this setting.
Truly life-saving. And ensuring people can perform this safely brings us to simulation.
Yeah.
How important are mannequin simulators in T training?
They're becoming incredibly important. Getting enough hands-on T experience can be challenging. It's semi-invasive, often done under time pressure, especially in the OR or cath lab. Simulators offer a safe space to learn.
How do they work?
You have a life-size mannequin, a dummy T probe with sensors, and sophisticated computer software. As you manipulate the dummy probe, the software generates realistic, anatomically correct T images on the screen, simulating the views you'd get in a real patient.
What's the main benefit?
It allows trainees to develop that crucial hand-eye coordination, understand the complex 3D spatial relationships between the probe movements and the resulting 2D images, and practice recognizing various pathologies, all without any risk to a patient. Studies have shown that fellows who train on simulators first gain proficiency much faster when they move to real patients.
Okay, we've covered a huge amount of ground. Let's try to summarize the absolute top takeaways from this deep dive into T.
Sure. First, I'd say T is just indispensable for getting high-resolution images of those posterior heart structures, the atria, LAA, mitral valve, pulmonary veins. And it's really become the gold standard for guiding complex structural heart interventions, like TEER or ASD closure, especially things needing that precise transeptal puncture.
Right. Second takeaway.
Safety and training are paramount. Mastery involves both deep cognitive understanding and refined technical skill. You need that recommended training minimum 50 supervised studies for level 2 independence and strict adherence to safety protocols, like managing thermal risks and knowing about things like methemoglobinemia.
Okay. Third.
TE plays a critical, often unique role in special settings, particularly in the ICU where TTE fails, and especially during CPR, where its ability to provide continuous diagnostic imaging without stopping chest compressions can be literally life-saving by identifying reversible causes like tamponade or PE.
And finally.
The path to achieving safe expertise is evolving. Technology like mannequin simulators is proving invaluable, letting trainees systematically practice and perfect those complex probe manipulations and anatomical understanding in a completely zero-risk environment before they ever perform the procedure on a patient.
Excellent summary. Let's do two final quick questions for our listeners. Question 9. What is T's key advantage during cardiopulmonary resuscitation, CPR? A, TE has higher resolution than TTE in all patients. B, TE is the only method that can determine heart rhythm. CTE allows continuous imaging and diagnosis of arrest cause without interrupting chest compressions, or DTE is preferred because it requires no prior fasting.
Focus on the CPR context.
The answer is C. The ability to image continuously without stopping compressions is its major unique advantage during CPR.
Definitely.
In question 10, which anatomical structure is generally visualized most clearly using the mid-esophageal ME window? A, LV apex, B, left atrial appendage, LAA, C, left subclavian artery origin, or D, hepatic vein tributary?
Thinking about that workhorse window.
The answer is B, the left atrial appendage. The ME window, around 28-30 centimeters deep, provides excellent views of mid-cardiac structures like the LA and LAA. The apex usually needs transgastric views, and the others are typically seen in UE or deeper windows.
Correct.
Okay, to wrap up, here's a final thought to consider. We've seen how simulators can help master T safely.
Yes, and it really makes you wonder, if we can hone proficiency for a complex procedure like T perfectly on a simulator before a trainee touches a real patient, how might this kind of technology change the standard training pathway for all invasive procedures in the future?
Could we reach a point where simulated mastery is a prerequisite? Ensuring expertise is built into zero-risk environment first.
It's a profound thought, isn't it? A potential paradigm shift in how we ensure patient safety and clinical competence. Definitely something worth thinking about as simulation technology continues to advance.
Absolutely. A fascinating look at a critical tool. Thanks for walking us through it.
My pleasure. It's a vital technique to understand.